Good morning, everyone, and thank you very much, Steve. It's an absolute honor to deliver this Joop Lange memorial lecture. Joop was, of course, taken too early in the Malaysia Airlines 17 tragedy, and someone who had, as Steve said, had dedicated his life to addressing the inequities in health, originally in HIV. Both Sharon and Gail are two hard acts to follow, but I shall do my best to review how inequities, all of you in this room here are obviously very familiar with inequities in HIV, but how inequities in COVID had been so amplified, and we still see the impact of it to now. Now, how does WHO define health inequity? And that is the absence of unfair and avoidable or remedial differences in health among population groups defined socially, economically, demographically, or geographically. I think there's no better cartoon to explain the difference between equality in health and inequity in health. If you pause for a few seconds to take in how equality and equity differ just from this excellent cartoon. Now, Sharon had already touched on the stark injustice, I guess, of the global vaccine inequity. That is vividly shown in the map on the right and the graph on the left, and how in high-income countries, 3 in 4 people have been vaccinated with at least 1 dose as of January 11th, and that corresponds to about 73%. Whereas in low-income countries, particularly in sub-Saharan Africa, only 1 in 3 have received at least 1 dose as of January 11th of this year. So that is at the global level the most, stark inequity that is going to impact us all. With ongoing, the inability to bring the COVID-19 pandemic to an end, and of course the concerns around with ongoing surges and outbreaks of new variants, the inability of the current vaccines that we have to further have its impact. But the inequities don't only exist within countries or at the global level. I think what we all saw throughout the last 2.5 to 3 years is the in-country inequities that have driven the pandemics within countries, and also the impact it has had on people who are either socio-economically deprived or for other reasons listed here, are much more impacted by the pandemic. Of course, for people in high incomes, lockdowns, as terrible as they were, didn't have the same impact as people who relied on daily wages and had to cope with lockdown. So these are just some of the impact of inequities on individuals within countries. Just some examples of that. In Malaysia and in Singapore, and I believe also in Thailand, where our countries rely very heavily on migrant workers. First, we saw it in Singapore, and then was followed by Malaysia, that a large proportion, disproportionately, of individuals who became infected with SARS-CoV-2 and COVID-19 were from the migrant workers population in Singapore, tens of thousands, and in Malaysia, that continued to lead to ongoing clusters, as we called them in Malaysia, which then spill over into the surrounding communities. And this is largely because of the terrible living conditions that many of these migrant workers lived in most of our countries, in really crowded, poorly ventilated dormitories or even houses. I visited some of these places where in Malaysia, when during the initial part of the outbreak, single or two-bedroom terrace houses surrounding factories in Malaysia, you would find anywhere between 20 to 30 migrant workers all piled in, living in these conditions. And it's no wonder that they became infected with COVID-19. And of course, prisons, where I've been working for the last 10 to 12 years on HIV, but prisons also were a very early concern of ours. And of course, I think in Malaysia there were at least 50,000 cases recorded in our prison setting of prisons. Prisoners and prison staff towards the end of 2022. So these are just some examples of how these inequities, greatly contributed to the pandemic in countries, but also to morbidity and mortality. And this is a rather graphic example of inequities in sex workers in Bangladesh, who were also subjected to gender-based violence during the COVID-19 lockdowns. And I think if we looked further, there's been many other examples of this. So in addition to causing or contributing to large pandemics in the countries, of course, the direct impact of mortality as a result of these inequities. And the UCL group, led by Sir Michael Mamet and in the UK, has done some very amazing work looking at the impact both on morbidity, mortality, and other impact. But this is on the direct impact of mortality and how clearly, I'm sorry that the colors may not be so visible, but what it shows is those in most deprived areas of London had a higher rate of mortality compared to those living in the more affluent areas of the UK. And in this review of COVID-19 mortality and deprivation of 95 papers from 5 WHO global regions, the summary from that review also showed that in the studies, mortality rates were higher in areas of socioeconomic disadvantage than in affluent areas. So knowing what we know, that inequities lead to increased pandemics, increased incidence, increased morbidity, and increased mortality, how has COVID-19 prepared us for future pandemics? Because all global health experts say that this is not the last. It's not a matter of if, but a matter of when we will see another pandemic. I think those of us who worked very hard during COVID-19 are praying that it will not be in our lifetime, but prepare we must. And if I can deconstruct these health inequities and see how some of the solutions can come about at the global level, at the macro level in terms of public policies, at the community level, and also at the micro level. What it requires is, of course, solidarity and interventions and innovations that we've seen in abundance, and both Sharon and Gail have touched on many of these. First of all, in terms of at the global level, I think many of you in the room would know that WHO and its member states are working on a new international agreement or instrument to expand on the scope of the current international health regulation, recognizing that the current instruments that we have at the global level was not enough to respond to COVID-19. So this was announced back in 2021, and just this early, a few weeks ago, it was cemented that they will move ahead to work on this international instrument and hope to have it finalized sometime next year. And this will provide, like I said, a broader scope for WHO and its member states to respond to pandemics and pay particular attention to issues like equity, equality, health systems, strengthening trade, and of course intellectual property, and that it should take into account and have a One Health and human rights approach. And other issues like an approach to funding that's fair and sustainable, hopefully will also be a major part of this new pandemic accord. The second thing that's taken place at the global level is the creation of an mRNA technology transfer program. Sharon touched on CEPI, which also is looking at vaccine manufacturing and production. This is a WHO initiative to build capacity in low middle income countries to produce mRNA vaccines through a center of excellence and training. So there will be a hub which is in South Africa through the African collaboration, but also as part of this technology transfer, a particular emphasis on regulatory system strengthening. So these are the orange is the South African hub with Afrigen, and 15 other countries in low and middle income countries have put up their hands to be the spokes. How this is going to pan out is still very much work in progress, but nonetheless the overall aim is to allow these countries to manufacture these mRNA vaccines, and obviously it cannot just focus on COVID-19. I've been given the honor of looking at as part of my role with the WHO Science Council in some guidance for these spokes and the hub on how to make this whole outfit, the hub and spoke of the mRNA technology, sustainable. So how do you select, other than SARS-CoV-2, what other either infectious diseases or cancer vaccines that these hubs can eventually, this hub and spoke can eventually work on. And so an emphasis on R&D and also regional importance, pathogens of regional importance is, I think, what these hub and spokes are going to have to focus on. Now, I think the third significant contribution of the COVID-19 vaccine, as you've heard from both Sharon and Gail, is the development of, well, it's not new in terms of the platform, adaptive platform trials, but certainly at a large global collaboration, one of which was the WHO COVID-19 Solidarity Therapeutics Trial, which we at UMMC and colleagues at the Ministry of Health also participated in. I think gave an opportunity for low and middle income countries to play a role in these very important studies, and hopefully in many of the other studies that you've heard that we need to continue doing in relation to COVID, whether it's vaccines or treatment of and prevention of long COVID, I think having these platforms is going to be very important moving forward. Now, so that's at the global level, but what about an in-country level? And so I think, again, one of the major, what we saw in a major way was the use of genomics technology in COVID-19, which was not just limited to high-income countries, but low and middle-income countries were also very quickly able to how shall I say, able to utilize the advantages of this genomics technology. As an example, in KL, in Malaysia, once the genome sequence was announced or published by Chinese CDC, both our lab at the University of Malaya Medical Center as well as the IMR, the Ministry of Health lab, were able to design in-house PCR test kits that allowed us, as early as in, I think it was in February, that allowed us to provide for diagnostic tests very early. I think past experience with SARS-CoV-1 in some ways made us a lot more alert to the potential impact of COVID-19, even as early as January, and got us working very, very quickly. So I think certainly having the capability of using genomics technology helped us in many ways, rather than waiting for the design of test kits that would come from more advanced economies, which is usually the case. So I think this certainly was one way in which between countries inequity was helped with our ability to use genomics technology. And of course, in terms of ongoing surveillance and whole genome sequencing, the rapid training and development of platforms, which particularly in South Africa, as we saw through its scientific investment in HIV, have led the way in terms of SARS-CoV-2 surveillance. But this is now being emulated in many low and middle-income countries to enable countries to do it themselves rather than wait for high-income countries to tell us. So these are just some, there's a summary of the power of genomics technology to reduce the gap, the inequity gap between countries in terms of science, and the ability to do many of these functions in-house in our own countries. Both Sharon and Gail have also touched on the role of drug repurposing in the treatment of acute as well as long COVID. And I think, again, the desperation to find treatment in the early stages of COVID-19 and an ongoing search for alternatives to treatment have renewed an interest in drug repurposing that also allowed countries in both low and middle income in low and middle income settings to partake in these kinds of research. The paper on the right, I'm proud to say, is from colleagues from Ministry of Health that was cited as the most read paper in terms of COVID-19 treatment by the JAMA network, and they looked at the efficacy of ivermectin treatment on disease progression. And the paper on the left is looked at the effect of fluvoxamine, which was the early paper on this was led by colleagues or infectious disease colleagues in Brazil. So I think this renewed interest in drug repurposing and the ability for scientists and clinicians to undertake these kinds of research is also moving forward going to be very, very important in terms of reducing the R&D gap between low and middle income countries and high middle income countries, to do very high quality research, I must say. And the search for repurposed drugs that will be, hopefully, the whole idea, I guess, is to make these potential treatment much more affordable in low and middle income countries. I think as effective as Paxlovid is, many countries are unable to access it because of its high cost. And finally, in terms of technology, of course, the explosion of digital technology in the public health response to COVID-19 in many, many, many ways. I think we in the health profession are incredibly conservative. The banking and finance industry, the airline industry have, totally gone digital, but it took a pandemic, I think, to wake us all up that perhaps telemedicine would be a good idea in a big way. So digital technology was used in many, many settings, in both low and high income countries, I think to a lot of effect in terms of messaging, good and bad, in providing misinformation as well as misinformation and disinformation. Like I said, telemedicine and all kinds of ways, and really this is the way forward. But of course, it also has its own sort of dangers in terms of creating digital divide, the term as it's used, in potentially also worsening inequities. But in its role in reaching out to the unreachable, both in terms of geographic locations during lockdowns, as well as people who are marginalized, including the LGBT community, who face severe isolation during lockdowns. I think digital technologies played a very big role in addressing those inequities. Now, finally, all this technology and all the advances in biomedicine obviously are incredibly important in responding to these pandemics, but I think without the mobilization of the communities, and this has certainly been also shown that in communities where there was a strong trust in the government and a strong community response, the overall pandemic outcome was much better. And there are many, many examples of community mobilization and innovation, and here's one example from here in Bangkok, including the bottom picture is of urban farming, and the top one is, I think, education for and by communities on the COVID-19 vaccination. And here's an example that APCOM, all of you here would be familiar, did a review of the community response in COVID-19, but for and by those affected by HIV, including the LGBT communities. And here's how the community clinic served by PT Foundation in Kuala Lumpur in Malaysia reached out to those at risk and assisted with services such as delivery of testing and delivery of antiretroviral therapy and so forth. So in closing, I think what we have learned from the COVID-19 pandemic in terms of future responses. Of course, all those biomedical advances and R&D are, are what we need and more of. But unless we address the inherent inequities within our societies, we will continue to not be able to respond to the pandemic, to any pandemic effectively. We've been seeing it in HIV. In fact, this year, this recent end-of-year report from UNAIDS is entitled Inequalities, and just to further kind of show that inequities is one of the reasons why we still are unable to end AIDS despite all the advances we've had in antiretroviral therapy and prevention measures. So to quote Sir Michael Mamet, we limped into the pandemic then in a perilous state, an unhealthy population marked by growing inequalities and a worsening of the conditions in which people are born, grow, live, work, and age, in short, in the social determinants of health. So unless we pay attention to these social determinants of health that put people at risk of becoming infected or unable to access prevention as well as treatment modalities, we will continue to not be able to respond as effectively as it could. And again, this is to quote from this excellent report, again from Sir Michael Mamet's group, entitled Building Back Fairer, the COVID-19 Mamet Review. There was an original Mamet Review that was that looked at 10 years after the description of social determinants of health, just at the beginning of COVID-19, and called the Mamet Review. And the group subsequently did one specifically around COVID-19. And again, it says, this is obviously in reference to the UK, that it's imperative that the government and other organizations charged with reducing health inequalities work more effectively to improve the conditions in which people are living and the structural drivers of these conditions, as well as positively influencing the choices that people make about behaviors. The government has the evidence about the overwhelming impacts of social determinants on health, but it has largely not acted on it, and certainly not at sufficient scale. So in this report, I'm not going to list the recommendations, but there are many in terms of addressing the socioeconomic gaps and inequities, the particular attention to children and education as well. The learning lost as a result of COVID pandemic has been devastating. And many other recommendations are contained within this report. And I end with this from the book, the La Peste, I can't say it in French. There's no question of heroism in all this. It's a matter of common decency. That's an idea which may make some people smile, but the only means of fighting a plague is common decency. In other words, looking after those who are less fortunate than us. So with that, I want to end on a pleasant, on a happy note. It gives me great pleasure to announce, on behalf of the IAS Educational Fund, the Mark Weinberg Fellowship Program in Asia Pacific. Now, Mark Weinberg is, of course, was a leading light in the IAS, in the entire HIV movement, the IAS, and upon his death, a Mark Weinberg Fellowship was established for Sub-Saharan Africa, and the aim is to train clinicians in Sub-Saharan Africa on clinical management, but also in developing clinical research skills and leadership. We have managed to have this extended to the Asia Pacific, and hopefully, not hopefully, but we will be able to roll it out this year, and applications will open next week on January 23rd. The idea is to have clinicians train in selected sites within Asia Pacific, including with Sharon at UNSW, with HIV-NAT here, and at UMMC and several other centers in, like I said, in clinical management as well as clinical research and leadership. So do learn more about it on the IAS website, and we look forward to seeing your applications and have you be part of this exciting program. And of course, do come to Brisbane. So thank you very much for your attention.